Okay, so welcome everybody. I'm just going to carry on while we're waiting for this camera to be sorted. Hopefully you can hear me. I'd like to thank you for joining us this evening at this webinar today. So, so my name is Stephen Blackburn. So I'm based at the University of Birmingham. I'm part of the NIHR Biomedical Research Centre at Birmingham. And I'm here today to facilitate today's talk alongside our expert, Dr. Rima Dhillon-Smith. First of all, we are delighted to see you join us today, even though we can't see you joining today. So this is our series of easy to understand online talks about the health research being carried out by the NIHR Birmingham Biomedical Research Centre. Today's talk, we're going to focus on the connection between the role of the thyroid gland and miscarriage. And that will be talked to you by Dr. Rima, who will come on in a second. So before we start, if we can go to the next slide, please. I'll join as a panelist. Oh, hello, Reem. I can see you now. I can see everybody. Excellent. Right. Let me just put my video on. There we go. Hopefully everyone can see now. It might take a couple of seconds to come on. So before we start, could we go on to the next slide, please, Rima? Thank you. So I'm just going to tell you a little bit about what the NIHR Birmingham Biomedical Research Centre is. So first of all, we are a collaboration between universities and the NHS. We are managed by the University Hospitals Birmingham NHS Trust, and alongside a partnership with the University of Birmingham, alongside with many of our other partners. If you can just click forward the screen to bring up the others of here. So we're part of the University of Birmingham, as well as a whole range of different other collaborations and NHS trusts across the West Midlands region. So we're publicly funded by the NIHR, which stands for the National Institute for Health and Care Research. And the NIHR is the research arm of the NHS. And at Birmingham BRC, we're not the only BRC in the country. There are about 20 other biomedical research centres like ours across England, all working to improve people's health. So what do we do? I'll just wait for Rima to catch up. So what we do is we work with doctors, nurses, and other healthcare staff alongside many of our researchers to take new scientific discoveries found in the science labs and turn them into treatments and diagnostics or procedures and new treatments to improve people's lives. Our research specifically focuses on the causes, effects, and treatment of inflammation. Inflammation is a normal part of everyday living. It's part of our normal healing process. And we've all experienced at some point in our life, whether it's through kind of injuries and pain and swelling, heat loss, loss of function or movement. A lot of that has been associated with different levels of inflammation. However, sometimes our body overreacts and we get too much inflammation, and that causes further problems. And that is linked with many health conditions, including arthritis, infectious diseases, diabetes, cancer, and many conditions affecting women's health and metabolic health. And women's metabolic health is the area that we're going to focus on in today's talk. So before we actually get started with the talk and introduce you to Rima, just a quick reminder that you can ask questions to our expert, that's Dr. Rima, at any point during the talk. Simply click on the Q&A icon at the bottom of your Zoom window. It is shown here on an arrow on the slide here. And if you put your question in there, we will ask questions to the speaker at the end of the webinar. Hopefully there's going to be lots of questions, which would be brilliant. And if there's too many, we'll try and pick the most popular ones there. And then hopefully we'll have a really good conversation, get some good answers from Rima. Just remember, we can't answer any offer any medical advice, so we won't be answering any questions relating to specific medical questions that you might have. Also, this webinar has been recorded. and we will share the recording with all of you tomorrow. So you'll be able to watch it again or share it with others who haven't been able to make it today. So Becky, I'm just checking that we are going to be launching the poll right now, if that's okay. And if you want, could you come in and explain what we're doing with the poll, if that's happening this evening?
No, we're not doing the poll. We'll move straight on to the talk. Thank you.
Excellent. Thank you, Becky. Right. So we go straight onto the talk. So my pleasure to welcome Dr. Rima Dhillon-Smith, who is works at the University of Birmingham. She's a clinical associate professor of gynaecology and reproductive medicine. So without further ado, I'd love to welcome Rima to the talk, and I look forward to it.
Thank you, Stephen. And thank you, everyone, for giving up an hour of your time this evening to listen to this talk. Hopefully you can all hear me and can all see the slides. Please do sort of pop up a message if there's any issues, because I think there is a bit of a delay on my camera, it looks like, but hopefully you can at least see me. So just a very brief background. I am a gynecologist. I'm a reproductive specialist, which means I look after women and couples who've had miscarriages or subfertility, and I have a particular interest in an area of medicine which we call reproductive endocrinology. So this is the management of hormones in the body, which are pretty essential to fertility and pregnancy. And I've spent the best part of the last 10-15 years of my career particularly interested in the thyroid. And what I will spend the next 20 to 30 minutes is sharing a very new piece of research that we've done. And I should just say at the beginning, this is actually unpublished. So I would say this really shouldn't go too much further beyond the webinar. We have been told by the journal we're allowed to share it, but it's not yet hit clinical practice. So I'll come to explain the relevance of that when I talk about sort of practicalities of how this new evidence should be translated into care. So just to start with a bit of basics, I'm sure plenty of you do know, but for those of you who don't know, the thyroid gland is a really important gland in the body. It sits about here in the midpoint of the neck, and it actually is shaped like a butterfly. So it's the one we're always taught is a butterfly-shaped gland. The reason I say it's really important is because the main hormone that it produces is something called thyroxine. And this is the hormone that controls your body's energy, your metabolism. So this is all of the breakdown of substances within your body. And the way that the thyroid gland works is under the control of the brain, and very specifically a hormone produced by an area of the brain called the pituitary gland, and it secretes a hormone called TSH, which stands for thyroid stimulating hormone. So quite easy to remember. And essentially there's communication between the brain and your thyroid, and essentially as long as that communication is intact and they are in harmony, then your metabolism should be well controlled. Now, broadly speaking, there are two main types of thyroid dysfunction. Again, many of you will have heard of. You have an overactive thyroid, or you can have an underactive thyroid. And essentially what happens in these conditions, so if I start with an underactive thyroid, it is pretty much as the name suggests. The thyroid is not working as well as it should. It is under producing the level of thyroxine that it needs in the blood. So if you were to do a blood test, you would find that your thyroxine levels would be low. And also in combination with the brain recognizes this. So the body will recognize that there is a low level of thyroxine. So the brain will say, okay, I need to work harder to make sure the thyroid is making more of that thyroxine. So you get a high level of the stimulating hormone because the brain is trying to, plug the thyroid and say, come on, you're not making enough thyroxine. But the thyroid is underactive, so it's not able to. So you get a low level of thyroxine. This is an underactive thyroid. And the treatment for that is levothyroxine. So you just literally replace the thyroid hormone that is lacking. The opposite is something known as an overactive thyroid. So this is essentially the other way round. The thyroid has gone into overdrive, as the name suggests. It is making too much thyroxine. And again, the brain recognizes it, the body recognizes it. So the brain is trying to slow the thyroid down. So you get a drop in TSH because the brain is trying desperately to stop the thyroid making so much thyroxine. Now, the reality is thyroid function is essential for just a healthy life, full stop. So a lot of this is relevant for people who are not necessarily even trying for pregnancy, but it's particularly relevant in pregnancy for a couple of reasons. So the baby does not have, or fetus, however you prefer to call it, does not have its own functional thyroid gland until around 18 to 20 weeks gestation. So pretty much the entire first half of the pregnancy, the baby is completely reliant on mom's thyroid hormone. So that's why it's really important that mom has a well-controlled thyroid, because baby is totally dependent until 20 weeks. And the reason for the implication of that is because the thyroxine hormone that goes from mum to baby is an essential part of baby's brain development. So historically, before we really understood and before we realized that thyroid function was, so crucial in that first half of pregnancy, and before we sort of picked up on it, lots and lots of babies were born, and they were born being essentially having had an underactive thyroid, which we call hypothyroidism. And they would have significant neurodevelopmental issues. And it's where the sort of historical term, which we used to say cretinism, came from, which we don't use anymore, but that's where that came from. It was babies who had underactive thyroids. And the other thing that's really important is pregnancy is really stressful. Pregnancy as a sort of condition, which I don't like to call it a condition because it's also a normal part of life, but in terms of the stress and the impact and the physiological stress that pregnancy puts on the body, it is huge. So you need your thyroid to work essentially 4 times harder in pregnancy compared to non-pregnancy. And that's why it's really, really crucial for pregnancy. So a bit about miscarriage. As I say, I've spent the best part of my career researching in miscarriage, and one of the reasons I'm so drawn to it is because I think it's an area we still have so much lacking in understanding and answers and care, quite frankly. It is sadly very common. Around 1 in 4 pregnancies end in a miscarriage. It is the most common complication of pregnancy in the world. 75%, so at least 3/4 of those pregnancy losses are in what we call the first trimester, so in those first 12 weeks. The prevalence of what we call recurrent miscarriage, and what we mean by sort of purest definition, is 3 or more previous pregnancy losses. And that doesn't have to be in a row. It doesn't have to be that, there was a baby seen on scan. These can be the losses that women have where they have a positive test at home and then they bleed and it turns negative. So this is called a biochemical pregnancy. It includes that. When women are having 3 or more losses, something else is going on here. So this is only around 1% of the population. So fortunately, while it is very common, it is less common to be in that sort of particularly difficult category where you're having recurrent losses. Sorry, my slides keep skipping across. And I think, if I'm honest, a personal bugbear I have is when people say, oh, it's common, at least you're fertile, all these kind of comments, which are very unhelpful to anyone who's had a miscarriage. I'm sure it won't happen again. Actually, we don't know that. And just as an aside, our research group in Birmingham, for those of you who do follow our work in miscarriage, we have just had some media reach on trying to introduce something called a graded model of care, which is where we say, why should you have to wait until you've had your 3rd miscarriage before we investigate or look for something? And actually, this is where thyroid function comes in, because thyroid function is really easy to test. A thyroid function blood test is 20 pence. It's a very cheap test, and it's something that's very easily treatable. So this kind of bears relevance to the rest of my talk. But miscarriage is unfortunately still very, I would say, misunderstood. So could the thyroid be involved in miscarriage? The short answer is yes, we know it is already. So if women have what we say true overactive thyroid or a true underactive thyroid, this is where both of the hormone measurements, so both the TSH from the brain and the thyroxine from the thyroid, are both abnormal. So it's a paired sort of abnormal result. And the reality is most women and men, if they have thyroid disease, will usually know, because actually if you haven't got enough thyroxine or you've got too much thyroxine, you generally feel it. That's what gives you the symptoms. What you wouldn't necessarily know is if your TSH is abnormal. So this is the brain signal, because you don't get symptoms from that. And this is what we then call subclinical disease. And there is increasing evidence now, in fact, we know it's very well established, that even if you have subclinical disease, so this is where it's a diagnosis from a blood test rather than having the symptoms, this is also linked to a higher rate of miscarriage. And in particular, it's subclinical hypothyroidism. So these are women, individuals who have a TSH that started to go high because the brain is sort of recognizing the thyroid is not completely working as it should. So the brain picks that up internally like a signal, and it increases its own production of TSH. But actually, when you measure the blood test, the thyroxine level is normal. And so a lot of people have dismissed it for many years to say, oh, well, but the thyroxine is normal. That's all that matters. That's not true. This is a warning saying something is not going right here. Why does the brain think the levels are not normal? Why is it going up? And that's what we're interested in researching in miscarriage. So I quite like this slide. I think it shows really nicely what we talk about when we're talking about TSH, because I think lots of people have this blood test, particularly if you've undergone infertility investigations. It's something that we test a lot of people. Now, essentially, you can have a normal range, you have an above normal, and you have below normal. Now, I just have to say, I have put up to 5 as normal, but what I would say is this was just the kind of average of all of what the reference ranges in the UK. So every single hospital, every single GP surgery, if they have their own blood tests, will have a slightly different, what we say, assay reference range. So one hospital, it might be 4.2, another hospital, it might be 5.2. So my 5, I've just gone with the average of most of the assays in the UK. So for the vast majority of you, if you have a blood test, it should sit between, your TSH should sit between 0.4 and 5, considered normal. As I said, allowing for assay variances. So we know now that if it goes above normal, so if it goes above 5, that we should treat it. And this is national guidance. So this is already in the guidelines that we produced with the Royal College of Obstetricians and Gynaecologists that I wrote and published last year. It's international guidance. Everybody accepts that for pregnancy, this is not relevant if you're not trying for pregnancy, but for pregnancy, if that TSH has gone above 5, this is a pre-warning to say the thyroid is not coping with something. There is a signal imbalance, and given that someone is about to become pregnant and put their body under considerable amount of stress, we should treat that. The group where there has been I would say, very long-standing area of debate is the one here I put in this kind of brownish colour. So this high normal. So it's between 2.5 and 5. So it's a sort of mid-range up to the top end of normal. Now, where this came from, why do people get obsessed with this number of 2.5? This came from a study that was published in 2000, in fact, I actually think it was 1999, in the US, where they did a study and said, oh, 97% of healthy individuals should have a TSH level which is below 2.5. So therefore, everybody in the country, in the world, should be having a TSH is less than 2.5. This has since been completely quashed. It was incorrect data and it was wrong. But the problem is, as soon as you send a message out like that and tell the whole world that they need to treat people who have a TSH above 2.5, it's very difficult to undo that. And I have plenty of friends, family, colleagues who I know who've been to fertility clinics, been to miscarriage clinics, and told they need to have their TSH less than 2.5. This is not true. This is based on old, inaccurate evidence. Now, I'm going to confuse you as I come to the results of my study later, but what I want to make clear is at the moment, normal is anywhere between those two ranges. But because of this area of contention, that we're not sure for definite, this 2.5 to 5, the question for us really was, is there any group that would benefit in this range here? We're saying that we think probably they're all fine, but actually, have we really looked at this? Have we looked at women who have recurrent miscarriages? Is there anything we can do in this kind of upper normal range? And that was ultimately the foundation of our research question. So we looked at the evidence first. There was a big trial that we led from Birmingham. I was one of the senior authors on which was called the Tablet trial. Now, the problem with all the existing trials is, and when I say trial, these are all studies where women have been randomly allocated. So these are all women who were trying for a pregnancy or they're in early pregnancy, and they were randomized to receive either levothyroxine, which is the thyroxine drug, or a placebo or no drug at all. The main issue with all of these studies is the main group they looked on wasn't the group I'm talking about, which is this high normal TSH. It was women who have something called thyroid antibodies, which is slightly different. So thyroid antibodies are molecules that the thyroid produces, which the theory is that they sort of attack the thyroid and therefore also potentially attack any other tissues in the body, including a pregnancy. So we do know that women who are positive for thyroid antibodies, they do have, unfortunately, higher rates of miscarriage and higher rates of preterm birth. So all of these trials actually were targeted primarily at that population. And unfortunately, all of the studies have shown that if you give thyroxine to women just for the group who have thyroid antibodies, so not taking into account their actual thyroid test result, their thyroxine or their TSH level, it doesn't change their outcome. But what we realise is actually all of these women and all of these studies, including our study from Birmingham in 2019, we will have the data. We will have all of these women's thyroid stimulating hormone results. This is thousands, right? So maybe we can ask the question, we can look into that data and we can say, if you have a high normal TSH and you have a history of miscarriages or subfertility, so, maybe we, reopen that question, would you benefit from thyroxine treatment? So that was, as I say, the foundation of the study. And what we did was something called an individual patient or participant data meta-analysis. So what that means is when you sort of traditionally do what we call a systematic review, where you gather all the data from all the studies that have ever been published on the area or the topic you're looking at, you generally don't get the actual data. What you get is the paper they published. So you just pull the numbers. So you would say, okay, 50 out of 100 women in that study had a pregnancy versus 40 out of 100 in the same study. But when you have individual data, what it means is, and we actually it took years, to be honest, because you're waiting for people to send you their actual data, and it includes data from China and the US, which was, if I'm honest, very difficult to get hold of, but we did in the end. So they have sent us their actual data, which means we've got a whole data set to analyze with everybody's blood test results, everybody's pregnancy outcomes for just over 3,300 women, which is the first time this has ever been done. And what it allows you to do is answer research questions that a single trial could not do. And as you can see, we had really good international representation. So 13 countries contributed data across 8 trials. So really nice big piece of work. So the question is, what did we find? And it was quite striking. I have to be completely honest. I did go into this as a sort of thinking that what I would find is no difference, because I thought, we know it doesn't really work in the subfertility population, and we've been trying to tell lots of other IVF specialists who I work with that, please, please, please stop putting women on thyroxine who don't need to be on thyroxine. Now, interestingly, and I will make really, really clear, the benefit we've seen is only in the group of women who have had a history of 2 or more miscarriages. But nonetheless, it's really, really clear finding and is practice changing, because we did not know this before and we weren't practicing this before. So what essentially we have found is, for all of the women who did not receive any treatment, whether it was a placebo or just no treatment at all, they had a 46% miscarriage rate. In the women who did receive levothyroxine, it was 25%. So almost half the miscarriage rate for those who received the thyroxine. Oops, sorry. And then obviously the sort of gold standard, it's not just about preventing a miscarriage. At the end of the day, what we want is for women and men and couples to take home a baby. So that we always say the gold standard outcome for any pregnancy trial or fertility related trial should always be actually live birth, and a live birth that is beyond 34 weeks. So it's a baby that we know has, grown to a reasonable gestation and therefore should be, a fairly healthy baby. So again, you see it here. So in those who didn't receive any treatment, it was 46.5%, and those who did receive levothyroxine, it's almost 60%. So this was honestly really surprising and I guess exciting, because this was an unexpected finding, and this is something we can genuinely translate into clinical practice and make a difference for those women who have, who are entering that 2 or more pregnancy losses. And if you were to sort of translate it into what does that mean in practical terms, these percentages, it means for every 10 women who've had 2 or more miscarriages, and they are in this category of having this high normal thyroid stimulating hormone level, if they take levothyroxine treatment, either preconception or early pregnancy, around 1 or up to 2 more couples will take home a baby compared to those who don't. So really, really big kind of impact on pregnancy outcome. One of the previous issues that there has been around just sort of putting everybody on thyroxine is that there has been studies that show that if you are on thyroxine when you sort of don't need it, or there's no evidence of benefit, essentially what you'll do is you will push up your own thyroxine levels, which is also not good either. You don't want too much thyroxine. It is quite a fine balance. And there were previous studies that suggested if you did this, you might see more premature births, you might see gestational diabetes, because you're sort of imbalancing the hormones in the body, higher rates of preeclampsia and other sort of serious side effects. Reassuringly, in the group we've seen, so again, very specific, women who've had 2 or more losses and they have this high normal TSH, we haven't seen any adverse events in that group. There was a bit of a suggestion in the women who'd had the slightly lower TSHs, and I think this is because they were essentially over-treated. So if you treat the right group, you're not doing harm, but it is a balance, because you can over-treat with thyroxine, and it's tricky. So the summary and the upshot is as to who should be tested and who might benefit from treatment. If you have had 2 or more miscarriages, we believe you should have your thyroid function tested. This is also in line with our proposal, as I mentioned earlier, for our graded model of care. So this is where we are trying to, currently in talks with the government, but the problem is the government is very unstable at the moment, but we are trying to encourage the government that there needs to be national rollout of a graded model of care so that women and couples do not have to wait till they've had 3 losses to have anything tested, especially going back to my point that a thyroid function test is so cheap and easy. Women with subfertility, they should be tested because actually they might have subclinical hypothyroidism that is undetected. So they could have TSH of, 6, 7, 8, but they'll never know because you don't have symptoms. So we think everyone who is being seen in a fertility service should have a thyroid function test. And of course, if you have symptoms, so, we know that around 1% of the population have a sort of true thyroid disease, so a fully overactive or a fully underactive thyroid, and they don't realise. So this is a reason for screening patient populations before they become pregnant. And as I said, and I keep hammering home because it is really, really clear, we actually did 3 types of analysis where we looked at women who had just pure subfertility, so women who'd never conceived a pregnancy, so no miscarriages, if you like. We then looked at women who'd had 1 miscarriage, and then we looked at the 2 or more. And in the sort of 0 or subfertile group, and in the 1 or less miscarriages, there was absolutely no difference at all. And actually, those were the groups where you were starting to see a bit of adverse effect from the thyroxine because it clearly didn't have any benefit. And I think one of the things that's difficult, and I understand this, and I hear this from patients all the time, especially if they've had a miscarriage, they will say, well, why not put me on something so it doesn't happen again? And the reality is because the chance of having more than 2 or more miscarriages goes from kind of 1 in 4 to 1 in 100. So it is genuinely a small proportion of the population who go on to have multiple miscarriages, and the problem is we can't just treat everybody for the sake of it. It has to be sort of targeted, proven treatment. It's a bit like saying, why don't you treat me for my blood pressure just so it doesn't go higher when I get older. You can't treat something until you know it's a problem or if you know there's evidence of benefit. And it is really important to get that balance. But what we can say definitively is if you have got this high normal TSH and you've had 2 miscarriages, it is worth considering treatment. What I wanted to share actually also was we have just published the American Thyroid Association guideline, and I've written a whole section within that guideline around women who have subfertility and women who have recurrent miscarriage. And actually, what we have suggested is that we think all of these populations should have their thyroid function tested, and you can push for that. So this is a published document that you can download. So it's ATA, it stands for. It's only just come out last month, actually, so it's very fresh. So to be fair, your GPs may not be aware of it, but this is international guidance. So if any primary care physician does push back on testing your thyroid, you can present this to them. But what we have adopted is a pragmatic approach. Now, all hormones in the body will go up and down. No hormones stay at the same level. Every hormone will go up and down depending on things like your time of the month, but depending on if you've got a viral infection, if you're particularly stressed, anything like that. Especially thyroid actually is quite sensitive to fluctuating. There was a huge study done in Denmark. It was several 100,000. They used sort of Danish registry data. And what they found is that for most people, if your TSH is below 6, it will actually completely normalize by itself within about 4 to 6 weeks. And when I say completely normalize, I mean actually go down to the less than 2.5. If your TSH is above 6, it's unlikely to do that. So if your TSH is above 6 on your first blood test, I would say just have treatment. That is true subclinical hypothyroidism, and you should be treated. But if it's that kind of, between 2.5 and 6 and you've had miscarriages, I would say it is still worth having another test before you jump in with treatment. And I'll explain why that is in the next slide, which I'll come to. Oops. Oh, blimey. Sorry. So the reason for not pushing the thyroxine, because it sounds like, well, this is a medication that you've just told me is safe. The studies show us that it hasn't caused any harm. But actually, the problem we have is it's really tricky to maintain a stable balance of thyroxine. So if your thyroid was going to correct itself, so if you've had one blood test and it was just a little bit high, and then your second one, it's come back completely normal. If you didn't have that second test, what you would effectively do is start your thyroxine treatment and you would push your thyroid even lower. So you would essentially push your thyroid into being overactive. Because what you would do is you would have too much thyroxine in the body because you've got your own level, which is normal, plus the thyroxine from the medication. And then your brain will think, oh my gosh, there's way too much going on here. I'm going to switch off my TSH. So the TSH then goes really low, which is an overactive thyroid. And that is equally as harmful in pregnancy. So that's why we have to be really careful. And all of these decisions need to come from a clinician, and you need to be monitored regularly once you're on levothyroxine. Equally, if you have too much thyroxine in the body, so if you've got quite high levels of free T4, which is the hormone we measure for thyroxine, there is some data showing that it is linked to lower IQ and also neurodiversity as well in children. So it isn't just a matter of, oh, this is the thyroid hormone, it's going to prevent a miscarriage, let's just take it. It is a bit more nuanced than that. And just one thing to kind of add here, going back to that question of why should you not give it to a woman who's had a single miscarriage versus a woman who's had recurrent? So when we talk about the causes of miscarriage, the most common cause, so 60% of miscarriages happen because of it sort of being an unhealthy fetus. And what I mean by that is there are hundreds and thousands of eggs within females, and there are millions of sperm within males. And not every single egg and not every single sperm will have the correct genetic material. So it only takes one slight abnormality in the egg or the sperm. They may fertilize and they may create an embryo, but that embryo then doesn't carry on developing because the genetics of it are abnormal. Now, it doesn't mean you have a genetic abnormality. That's just what happens. It can't be perfect every time. And that is the single most common cause of miscarriage. And that is the most common cause for those individuals who have one miscarriage. Once you are entering 2, 3, and certainly 4, what we call very high order miscarriages, this is where we believe it's no longer the embryo. We think it's something else. And actually, the data shows that. The data shows the more miscarriages you have, the less likely it is to be a genetic problem with the embryo. It's more likely to be something else. Is it, your blood is clotting too easily? Is it that there's an abnormality in the lining of the womb? Is it the thyroid? And we think that's why we're seeing this difference here. We think the reason there's this really clear difference between women who've had 2 or more losses versus those who've had fewer is because those women are the women who have got this subtle thyroid dysfunction that does need treatment. So I hope that makes sense because it is quite nuanced. And obviously you can ask plenty of questions at the end. So what does it mean for you? I don't know why it keeps doing that. What I would say, bringing back to my original point, this study data, so at the moment we have literally just submitted it to the Lancet, so we believe it is a huge game changer in the field of miscarriage. We haven't actually found any treatments for miscarriage, if I'm honest, in the last 20 years, apart from progesterone has shown some benefit. So this is really big for us, and we want to make sure the messaging gets out. So we're targeting a high impact journal, and it will pick up a lot of media coverage when it's published. But unfortunately, it's not out yet. So in defense of your GP, they will not know this. But what you should definitely consider is that if you have subclinical hypothyroidism, they should be treating that. And I think I would push for at least having a recheck when you're pregnant in early pregnancy, because that's really when it makes the difference. As I say, so if your TSH is above 5, you should be treated. That is out there. That is published guidance. That's both in the Royal College of Obstetricians and Gynecologists and also the American one that's just come out. But it is really important before you sort of start medication, stop medication, change doses. It is very much a kind of nuanced sort of changing the dose, adjusting the dose depending on the thyroid function. Anyone who has been pregnant and has been on thyroxine, you'll know this. We're constantly titrating it up and down, take this dose on this day, this dose on this day, because it's quite a fine line of balance getting the correct reference ranges right. But hopefully, there is a proportion of people now who we think genuinely this research will help. And that's why we're really keen to get it out in the public domain as soon as possible. So I think I've hammered home this point probably about 100 times through this talk. But if you've had 2 or more miscarriages and you have a high normal TSH, taking thyroxine could potentially nearly half the risk of you having another miscarriage. But it is that specific population. We do think it's safe in that group. The groups we have to be careful of is where we're over treating, and that's why if you are on it, you do need to be monitored. I think generally in the UK, we're pretty good at monitoring thyroid function in pregnancy, but do just make sure it's being checked every 4 weeks or so. That's the national guidance. Please remember, not everyone needs treatment. My take home here is not that everybody should go out and be on thyroxine. That's not the right thing to do. And going back to the sort of one of the slides earlier where I talked about thyroid antibodies, this is an area we still need to learn a lot about. We know now that it's not to do with the thyroid antibody. So just as additional information, we also did an analysis in this study looking at women who had thyroid antibodies versus didn't have thyroid antibodies, and giving thyroxine made no difference whether they had antibodies or not. It's not to do with the antibody. I think, and what we all believe in the field is that if you have thyroid antibodies, this is more likely to represent what we call an autoimmune dysfunction. So this is something to do with the way that your body, for want of a better word, sort of attacks or doesn't, receive a pregnancy the way that it should do, and the placenta develops abnormally. And so we are, in fact, we have funding. So we have funding in Birmingham. We're doing a study in Birmingham, which will become a national study, looking at trying to understand the immune response in women who've had recurrent miscarriages and who have thyroid antibodies, because this is clearly a different pathway that we need to understand better. So hopefully I'll have more to update on that in the future. So thank you for listening. I don't know how long I took on that. Hopefully it all made sense, and I'm really happy to take questions.
Rima, thank you so much. Excellent timing, by the way, and very, very interesting talk. Thank you so much for that. So I hope everybody enjoyed it. We've got plenty of time now to answer some of your questions. I can see that there are quite a few questions already being put into the Q&A, so please keep adding them. So let's start with kind of the first one, actually, that came through very early on in the talk. And it's with the focus on the TSH testing itself. So you mentioned in your talk that it only costs about 20p for each test. So the question is, why does it take 3 miscarriages to get a test? Is it not a normal blood test to have when pregnant?
So it's a good question. So in pregnancy, it's not, there is lots and lots of data shows it's not advocated for routine pregnancy. There's been lots of cost effectiveness studies showing that the pickup rate in pregnancy is actually really quite low, especially for low risk population. What we do suggest, if anyone has any risk factors, and this is all in the guidelines, so if you have a family history of thyroid disease, it's quite a long list, I won't read the whole table, but if you have a family history of thyroid disease, if you have thyroid antibodies, if you have a history of miscarriages, if you have a history of subfertility, these are just the kind of most common ones, you should be tested in pregnancy. So actually you should be, is the short answer to that. The 3 miscarriages background. So this is actually why we're trying to introduce this graded model of care. And I think maybe that was asked before, right? I'd mentioned that because we don't believe you should wait 3 miscarriages to have your thyroid function tested. The reason we're trying to introduce this graded model of care is because actually by the time you're getting to the point of 3 miscarriages and more, we're talking about quite specialist tests. So things like what we call a 3D ultrasound scan, genetic testing for parents, something called antiphospholipid syndrome. And these are all really, if I'm honest, quite rare things. So that's the 3 miscarriage, but actually even 1, I would say. If you've had 1 miscarriage, I think you could ask your GP and just check you haven't got subclinical or even a full thyroid disease, because it's so easy to treat. And if I'm honest, I don't think, maybe I'm incorrect, but I don't think many GPs would say no to that, because GPs do it all the time. I don't think they would agree to refer you to a clinic, which is correct, but I think they would do the blood test.
Thank you, Rima. Hopefully that answered the question, and thank you for that. So we have a couple of questions that are asking for the links to the reports that you've mentioned in the guidance. I think we can probably put that in the chat as we speak. If we can't do that right away, we will be sending that out alongside the kind of recording. But Rima?
Yeah, the RCG one is published, so I can I can try and pull it up now. Or will there be an email or a link I can send to everyone on the webinar after?
Yeah, if you share that afterwards, we can share that out with the recording as well.
Okay.
That goes out to everybody. But
Yeah.
so that would be really, really helpful. And I know that, Becky, thank you for posting some of those links in the chat there as well, if anybody's needing support relating to their pregnancy or miscarriage related issues. Got a question from Sarah. if you have multiple miscarriages with a thyroid condition and then have a live birth in between, is this likely to be non-thyroid related, or could it still be linked?
It's a tricky one. I would say it depends on how many miscarriages. I think if it's multiple, if you're saying 2, 3 miscarriages, then yes, it could be that in those pregnancies, the thyroid wasn't optimally stabilized. And it could be. I think the reality is you'll never know. But yes, having a live birth doesn't mean that you have not been affected by thyroid dysfunction, which has caused a miscarriage previously, especially because it's so volatile. It changes all the time. So anyone with multiple, well, anyone who has a known thyroid condition, if you're on thyroxine, should be being monitored in pregnancy, because we know that the demand on the thyroid is so significant in pregnancy. So I can't tell you with certainty, but I wouldn't rule it out.
Thank you, Rima. I've got a question about the impact of people's ethnicities or backgrounds on this. And this, I think the question is more generally in terms of miscarriage. Does the predominance of different causes alter with age or ethnicity? But also in terms of your research findings as well, did you specifically look at age or ethnicity?
Yeah, we did. So we know, unfortunately, the number one cause for miscarriage, or not say cause, but the risk factor, I should say, unfortunately, is increasing maternal age. And the reason for that is essentially that as we get older, our egg quality goes down. And egg quality is directly linked to genetic quality. So that's what we really mean. So when I was going back to that sort of the number one cause for miscarriage is the embryo, the sort of unhealthy genetics of the embryo. Unfortunately, that is very much higher in women who are older, because as we're older, we're much more likely to have eggs which have reduced quality genetics. And so when you draw a graph of miscarriage risk, it goes up very significantly. Certainly above the age of 40, the miscarriage rate is very high, and it's because it's predominantly embryo driven. But I wouldn't use that as a reason. So if I had a 41-year-old who come and she's had 2 or 3 miscarriages and she's got a high normal TSH, I would treat her. I wouldn't say, oh, it's just because you're 41. I would still treat her. But unfortunately, the age is a sort of additional barrier, if that makes sense. I feel like there was a second question in there. I did see it. Where was it about ethnicity? Yeah. So
Ethnicity.
we've done quite a bit of research which has shown that South Asian and Black women have higher rates of miscarriage, but we can't seem to explain that. We did look in the analysis here. It didn't make any difference for our analysis. So it didn't matter what your ethnicity or your age was, there was still a benefit with the TSH. But there is a known background disparity in pregnancy loss, with it being higher in Black and South Asian groups, and we don't know why, sadly.
So further research maybe
Yeah,
on
yeah.
that one. Thank you. So the next question is kind of sort of thinking a little bit more broadly in terms of women in menopause. The question is, considering this is speaking to female hormones, do you see a link with women in menopause and not optimizing thyroid hormones if blood test results in borderline normal? So when do you treat when do you treat in menopause?
So the general rule of thumb, and again, this is within NICE guidance, National Guideline on Thyroid Management outside of pregnancy, so in non-pregnant populations or populations who are not trying to conceive, which ultimately would be menopausal women, is that actually there is very little impact from borderline TSHs in these groups. And in fact, for context, there was a study done probably a few years ago now, which showed you can actually have, I'm not sure how much I believe the study, but it was published in the BMJ. You can have a TSH level above 100, believe it or not, and apparently be absolutely fine. Nobody would, if I'm honest, I don't think any clinician would actually be okay with not treating that. So the general rule of thumb and the UK guidance is that if your TSH is above 10, so it's a very different threshold. If you're not trying for pregnancy, it's a very different threshold. And the reason is because of the demand that pregnancy puts on the thyroid. So your thyroid, just for context, only ever works at about 50% of its capacity, and in pregnancy it goes up to 90%. So it works a lot harder than it does normally in pregnancy.
Wow, thank you. A question from Hannah Scott. How frequently should your thyroid action be measured? If it can fluctuate so much, how can it be monitored in a way that can specifically tie in the factors affecting it?
Yeah, it's a really good question. To be honest, there is so much argument and debate about this. You can have endocrinologists talking about this for hours. The short answer is it depends. So if we're talking about pregnancy or preconception, let's start with preconception. If we're talking about preconception, I would, as a fertility clinician, I would want someone to have a normal thyroid function within 3 months of a pregnancy because that will should tell you a snapshot. If somebody is not trying for pregnancy, but has thyroid antibodies, for example, so thyroid antibodies increase your chance of developing an underactive thyroid. I would say if you're not trying for pregnancy, once a year is actually enough, as long as you're having annual checks. So it essentially depends on how close you are to trying for a pregnancy. I think what's tricky is obviously I see women who are literally about to come through for IVF, so it's a bit different because they're sort of imminently about to hopefully become pregnant. I think if you're out in the community, I would say as long as it's within the last 6 months, that's okay.
Okay, great. That's very clear. Thank
And
you.
again, that's in the RCOG guideline as well, actually. So yeah.
Okay, thank you. There's, oh, let me just, I think I've pressed the button. Okay. Okay, so next question is, should thyroid function be rechecked after a miscarriage before attempting another pregnancy?
Yeah, so I mean, like I say, the guidance really is two or more losses, because the vast majority of that one pregnancy loss will be in that sort of not the correct, not the healthy embryo group, and you're the percentage chance of you having one loss and then going into two drops from, as I said, 25% down to 1% of the population. But as I say, I genuinely think if you've had a miscarriage, it's such a cheap test. I don't think most GPs would say, no, sorry, absolutely not testing you for your thyroid function. I think there's grounds medically because you could have an undiagnosed thyroid disease. The one thing I would say is it does need to be at least 6 to 8 weeks after a miscarriage is resolved because the miscarriage itself can alter the function. So it needs to be sort of at a stable kind of post-loss time point. So at least 6 to 8 weeks after a loss, we would recommend checking. Definitely, if you've had two, if you've had one, I think you can ask the question. But if your GP doesn't do it preconception, what you can do and what the national guidance does say is that if you then become pregnant, you would be considered one of those risk factor groups who should have it tested in pregnancy. And as I say, I'll send the links for the guidelines because you can show them it's in the table.
So just a related question. Do you think the testing of thyroid is widespread enough, in your opinion?
Is it good question. I think it is, but I think it's not actioned appropriately. So I get a lot of GP referrals for fertility where women have got bond or subclinical hypothyroidism. I'm talking TSHs above 5, 6. I'm not talking about this high normal. And they've not been treated. And I always say, okay, well, I don't know whether this is the one thing we just need to do before we jump into IVF. So I think GPs are very nervous about treating subclinical disease, and I don't quite understand why, but that's what I would say. I think they test, but I don't think they treat unless it's a truly overt condition.
Wow. Okay, thank you. The next question, actually, I suspect that the treatment and medication is available by the NHS, but it may not be for everybody. This may be a call from abroad. So is the medication affordable for people who need to pay for it?
Yeah, it should be. And like you say, it is on the NHS. I mean, ironically, thyroxine, for anyone who's had thyroid surgery will know this is one of those lifelong free prescriptions. Incidentally, even if you started on for fertility, I have been told, although someone might correct me on that, but I have been told once you are issued a thyroxine prescription, because it is in that category of lifelong medication, which ironically, for this purpose, it isn't, because as soon as you have your baby, you should stop taking it. So it should be free, but then, like you say, that might not be for a UK resident. It's a cheap drug, is the short answer. It's not expensive.
Right. Okay. You did talk about this kind of side effects that there was likely little harms, but are there any known side effects of levothyroxine?
Not not really, because essentially it's the same hormone that your body is lacking. That's why you're having it. The issue of when things sort of creep in and where problems arise is if you're over-treated. So if you have too much thyroxine in your blood, then you will have symptoms of an overactive thyroid. And this is things like sort of fast heart rate, this is sort of sweating, kind of very much intolerance to the heat, a lot of weight loss, hair loss. So if you start to get any of those things and you're on thyroxine, I would say go and get a test because it sounds like you probably need to drop your dose down.
Okay. Few more questions we can fit in. The next question is from Deb, and this might actually need a little bit of explaining. I suspect Deb knows a lot about this issue. So has there been any difference in response to treatment for people with subclinical hyperthyroidism caused by hemithyroidectomy versus innate hypothyroidism? So if you could maybe unpick some of that and then answer the question.
I'm wondering if Deb is an endocrinologist, but I essentially the short answer is we haven't looked in quite that detail because obviously the population. So just to explain for the others, so essentially we're saying, is this a sort of natural occurrence of the TSH has gone up but the thyroxine is normal versus someone who's actually had thyroid surgery, so had half of their thyroid removed, and therefore it's kind of an external cause for the change in thyroid function. The short answer is I don't know. We haven't looked in that much detail in all of the trials. I can actually say none of the women actually had hemithyroidectomies, which is quite interesting finding in itself. So no, don't know. Interesting question, and I can definitely have a think about that to look in future research.
Good. I didn't quite understand it when I was saying it. So, your study looked at 13 countries. Are you looking to extend that to more countries around the world?
So it's just because that's where the trials had been done. So the data came from the countries that had done the studies that we then collected the data from. What we will do is, so the ATA guideline, which has just been published, I mean, I think it's this month actually, it's just come out. What the plan is, because I'm one of the co-authors, is and because we know this is practice changing, normally a guideline wouldn't be updated for another several years, but we are going to put out a kind of update addendum because we know this needs to go in. So it will become international guidance, hopefully within the next few months. We just need to get it published first, and then we can put it in the guideline.
Good luck with that. I think we'll come to the maybe the last question here, but this is a question maybe that's something you could consider about within your research or your future research. It's an interest from someone who's interested in getting involved from a public involvement perspective. So maybe you could talk about the public involvement in your work, and then if there's opportunities in future research.
Yeah, no, absolutely. So we have actually just set up, so I don't know if there is a way of this person being able to contact me. I mean, I've got a university accessible email that you feel free to contact me. But essentially, we have got a Birmingham-based PPIE group in specifically around miscarriage. But we also work very closely with the British Thyroid Foundation, who are the UK's governing body for thyroid disease. And we also try and there's a few of us who link up in thyroid disease and pregnancy. And we've got a PPIE group there. So yeah, there are groups and we're always keen for more people. So yeah, if you're interested, I would say if we can try and be linked some way. I'm happy for my email to be given, Stephen, if that's helpful.
I think we can put that as part of the link out anyway, so people can get in contact if they're interested. Next question, not to go into too much detail, but I'm just wondering whether you could comment on the question from Tahira, which is talking about the role of stress on impact of successful live birth in people with thyroid dysfunction.
So I wouldn't necessarily know about, I mean, so yes, so the first thing to say is the thyroid is quite susceptible to changes in stress, and that's why I said it fluctuates. So if you are particularly under stress, then yes, your thyroid can work harder. So yes, that is true. But even separately to that, we did a piece of work about the impact of stress on pregnancy outcomes, and there's a huge body of evidence now showing that jobs where there is high impact stress, and particularly actually night shifts, so people who work abnormal shift patterns, and work a lot of night shifts, which is not sort of conducive to good health, is linked to higher miscarriage rates. So there is so much I think that we don't do very well, and we don't explain very well to sort of the public, I would say, about risk factors for miscarriage.
Okay, thank you very much. Right, I'm going to draw that to an end. Unless you can answer one of the final questions, Rima.
I can just go really quickly. So I think that's functional neurological disorder. No, there's no association as far as we know between thyroid dysfunction and FND. General question, if I have, yes, it could be. So if you have a goiter, I would want probably surveillance on your thyroid function. So probably once a year would be okay for the person who has a goiter nodule. How do we treat positive antibodies? Well, that's the problem. We don't know. So we thought that if you gave these women levothyroxine, you could control their thyroid and the antibody wouldn't cause the pregnancy loss or the preterm birth, but that's not the case. So we think it's probably going to be an immune type therapy, but the short answer is we don't know. And Samaya, oh, I think I know Samaya. It's nice to see her on there.
Yep. So thank you, everybody. Thanks for your questions. Some really, really good questions. Thank you, Rima, for providing such comprehensive answers to those questions as well. Could you just click onto the next slide, if that's okay?
Oh, yeah.
So we've just got some general information questions for you. If you're interested in taking part in research studies, particularly whether it's related to pregnancy or miscarriage or experiences of hypothyroidism, then, or any other research study, you can go on the Be Part of Research website from the NIHR, where you can look for research studies which are of interest to you in close to your area. So the link to that website is also on the chat. Secondly, if we can click onto the next slide as well, please. So this webinar series has been brought together, working together with our public contributors within the BRC. We really thank them for their time and contribution, and everybody who's involved in research anywhere, really. So we involve members of the public, people with lived experiences, patients in the work that we do, and we're always looking out for new people to join us. Your lived experiences, whether they're good or bad or indifferent, they're really, really important to research. And it's really important for us to hear what those experiences and also your suggestions and ideas for how we do research. It makes a real big difference. There's lots of different ways you could be involved, and it could be something that can be regularly or just one-off, whatever suits that meets your time and preferences and other commitments, of course. So if you want to find out more about getting involved in the research that we do, we've put a link in on the chat to find out how you can work with us to shape research as a patient or a member of the public. So you can click on that link and you can go through and register your interest. So if you want to find out a little bit more about getting involved in research, you can go onto our website. And on that website is information about patient involvement, public involvement, what it's like to be a member of the public and being involved in research. We have groups across all of our different research teams that you can have a look and see whether you would be willing to find out a little bit more and potentially join as well. So if we go to the next slide. So just before we end, I want to thank you again for joining us this evening. I hope you enjoyed the talk. I found it really, really interesting. But most of all, thank you to Dr. Rima for her time this evening, and also for providing such a very clear and very interesting talk as well. So unfortunately, that's the end of our series of easy to understand science talks for this year. We're hoping to come back in the autumn with a new series of talks on different topics that are being researched within the NIHR Birmingham Biomedical Centre. So look out for information on that coming through to your emails. As I said, we've not got a definite program yet, but we're hoping to be back in the autumn with a new series. We'd really love to hear your feedback on this session or any previous sessions you've been before, on what you might want to hear about in future talks, or how we may be able to improve these talks going forward. So we've just popped the link in there on the chat for a feedback form. It'd be great if you could fill that out. It only takes a few minutes. Any feedback you could give, that would be really, really helpful. So I'm hoping we can see you for our next talk. I'm really keen that we do it, but thank you so much for joining us this evening, and I wish you a good evening.
Thank you.
Thank you, everybody.